Thank you for your interest in our e-poster. It's entitled Relevance of Respiratory Tests in Determining Respiratory Involvement in ALS. I will begin with our take-home messages. So we identified three different phenotypic respiratory patterns in ALS according to the questions 10 and 11 in the ALS-FRS-R. Orthopnea is in fact a severe symptom in ALS which should prompt rapid non-invasive ventilation. Early NIV adaptation allows for a similar survival in between the three phenotypic patterns that we identified, and the evaluation of ALS patients at first visit should be done using different respiratory tests. Respiratory insufficiency and its complications are the main cause of death in ALS. Dyspnea occurs initially during great respiratory efforts, but eventually at rest, and the orthopnea can be seen as a further aggravation of the respiratory function. These two symptoms are addressed in the ALS-FRS-R, specifically in questions 10 and 11. With our study, we aim to evaluate if these symptoms, as scored by these questions, represent different respiratory phenotypes in ALS and to study their association with volitional and non-volitional respiratory tests. And so we divided our patients in three groups: G1 without respiratory symptoms, G2 with only dyspnea, and G3 with dyspnea and orthopnea or only with orthopnea. In all these patients, the respiratory measures were done within a 2-month time frame. We recorded demographic characteristics and also the results in different respiratory tests in addition to the ALS-FRS-R. We considered for the respiratory tests the cutoff values that are described in the literature, namely for forced vital capacity, MIP, MAP, P01, blood gas analysis, the mean amplitude of the CMAP by phrenic nerve stimulation, and the nocturnal pulse oximetry. The three groups presented significant differences regarding the respiratory tests, and indeed there was a significant decay in all the values of these tests in between G1, G2, and G3. The independent predictors of being included in G1 were MIP, P01, the mean amplitude of the CMAP by phrenic nerve stimulation, and the mean oxygen saturation during nocturnal pulse oximetry, and for G3 only the mean amplitude of the CMAP by phrenic nerve stimulation was predictive. Three different phenotypic respiratory patterns should be considered in ALS, being G1 patients younger with better respiratory functioning. The decline in the respiratory function seems to parallel the decline in the motor function, which is probably useful in future clinical trials. NIV, early NIV adaptation, is an important factor that modifies the natural course of the disease and should be considered in these subgroups, especially in G2 and G3. And at first visit, even though MIP has an high sensitivity for detecting early changes, we all know that it has an early floor effect. So different respiratory tests should be considered, and with significant relevance for the mean amplitude of the CMAP by phrenic nerve stimulation that can selectively grade the patients that have more severe diaphragmatic involvement. And we thank you for your attention.